If you lined up all the blood vessels in your body, they'd be 95,000 kilometers long. And every day, they carry the equivalent of over 7,500 liters of blood, though that's actually the same 4 or 5 liters recycled over and over, delivering oxygen and precious nutrients like glucose and amino acids to the body's tissues. All that blood exerts a force on the muscular walls of the blood vessels. That force is called blood pressure, and it rises and falls with the phases of the heartbeat. It's highest during systole, when the heart contracts to force blood through the arteries. This is your systolic blood pressure. When the heart is at rest between beats, blood pressure falls to its lowest value, the diastolic pressure. A typical healthy individual produces a systolic pressure between 90 and 120 millimeters of mercury, and diastolic pressure between 60 and 80. Taken together, a normal reading is a bit less than 120/80. The blood traverses the landscape of the body through the pipes of the circulatory system. In any plumbing system, several things can increase the force on the walls of the pipes: the properties of the fluid, extra fluid, or narrower pipes. So if the blood thickens, a higher pressure is needed to push it, so the heart will pump harder. A high salt diet will lead to a similar result. The salt promotes water retention, and the extra fluid increases the blood volume and blood pressure. And stress, like the fight or flight response, releases hormones like epinephrine and norepinephrine that constrict key vessels, increasing the resistance to flow and raising the pressure upstream. Blood vessels can usually handle these fluctuations easily. Elastic fibers embedded in their walls make them resilient. But if your blood pressure regularly rises above about 140/90, what we call hypertension, and stays there, it can cause serious problems. That's because the extra strain on the arterial wall can produce small tears. When the injured tissue swells up, substances that respond to the inflammation, like white blood cells, collect around the tears. Fat and cholesterol floating in the blood latch on too, eventually building up to form a plaque that stiffens and thickens the inner arterial wall. This condition is called atherosclerosis, and it can have dangerous consequences. If the plaque ruptures, a blood clot forms on top of the tear, clogging the already narrowed pipe. If the clot is big enough, it can completely block the flow of oxygen and nutrients to cells downstream. In vessels that feed the heart, that will cause a heart attack when oxygen-deprived cardiac muscle cells start to die. If the clot cuts off blood flow to the brain, it causes a stroke. Dangerously clogged blood vessels can be widened by a procedure called an angioplasty. There, doctors thread a wire through the vessel to the obstructed site, and then pass a deflated balloon catheter over the wire. When the balloon is inflated, it forces the passageway open again. Sometimes a rigid tube called a stent is placed in the vessel to help hold it open, letting the blood flow freely to replenish the oxygen-starved cells downstream. Staying flexible under pressure is a tough job for arteries. The fluid they pump is composed of substances that can get sticky and clog them. And your typical healthy heart beats about 70 times a minute, and at least 2.5 billion times during an average lifetime. That may sound like an insurmountable amount of pressure, but don't worry, your arteries are well suited for the challenge.
Hi guys, my name is Sanjay Gupta. I'm a consultant in York. Today I wanted to do a little video on the subject of blood pressure. If there's one thing that causes a ton of anxiety, it is the mention of high blood pressure. A common scenario, for example, is that a patient goes to see his doctor for a routine visit or an unrelated complaint, and then the first thing the doctor or the practice nurse will do is measure their blood pressure. Then the doctor shakes his head and says, "Oh, your blood pressure is a little high today. Maybe you should come back again and have it checked again next week. And if it is again high, then we will consider putting you on tablets." And the poor patient is immediately left feeling really anxious and worried about this. He goes home, he consults Dr. Google, and everywhere he looks there are these horror stories of how high blood pressure can cause strokes or heart attacks or kidney failure. And then when the poor terrified patient goes back to the doctor to have his blood pressure checked, he's already so anxious, and unsurprisingly his blood pressure measures high, which then triggers off more anxiety and the prospect of taking medications for the rest of his life. So this video is for that patient, and my aim is to help that patient understand and demystify the concept of blood pressure by asking the doctor 3 important questions before contemplating medications. Okay, as far as I see it, this number, the blood pressure number, is only important for 2 reasons. 1, the number is a symptom of something else going on in the body, and in which case the aim should be to try and identify the cause of this number being high and treating it. Okay, it doesn't make sense to make the number look prettier, I give tablets to lower the number, if the number is a sign of something else, because if you just treated the number, then you're missing the underlying problem. So the first thing I would say is that the number is important if it's a sign of something else, in which case you want to identify it. And 2, the number by itself, if the number by itself is causing harm, then that's important too. And in that sense, in that case, it does make sense to reduce the number. If the number itself is causing harm, then it does make sense to reduce the number. It's also true to say that we are all different, okay? And therefore it doesn't seem logical to me to have this one value which defines everyone. So the current guidance, for example, in the UK where I am, is that if your blood pressure is over 140/90, you have high blood pressure. Well, that doesn't make sense because we're all different people. So why do we have to rely on one value to define us? Surely what we want to know is whether that blood pressure is high for that individual. So instead of asking, is my blood pressure high, what we should be asking, and what we should get the answer to, is the question, is my blood pressure high for me? Okay, so here are 3 questions that you want your doctor to answer for you before you even start worrying about your blood pressure, all right? So the first question you have to ask is, what is my number? You know, what is my true accurate blood pressure? Now, the first thing to say is that the blood pressure in number fluctuates wildly in everyone throughout the day and night. And it depends on so many things. It depends on what they're doing, whether they're stressed or relaxed. It depends on whether they're exercising or they're at rest. It depends on whether they're awake or asleep. So it doesn't make sense to use isolated values to gauge whether a person's blood pressure is high or not. In fact, the most inaccurate way of measuring blood pressure is in the doctor's surgery, because the patient is stressed, it is an artificial surrounding, and it is not truly representative of that person's blood pressure. So this kind of poor patient who's gone and has his blood pressure checked, that's an inaccurate value. Okay, a more accurate way of measuring blood pressure is to do serial blood pressure measurements at home, or an even more accurate way is to have a 24-hour blood pressure monitor. The 24-hour blood pressure monitor, what that does is it makes automated recordings of the blood pressure several times during the day and night, and then it allows the doctor to calculate an overall average, and that average is a far better and more accurate representation of the blood pressure rather than isolated values. So the first thing I would recommend, if you're faced with the prospect of having high blood pressure, is to ask your doctor, what is my number? Please do a 24-hour blood pressure monitor and tell me what my average number is. And you'll be surprised, because actually very often the average number is far lower than these isolated values that are measured in the doctor's clinic, upon which a lot of doctors will start patients on tablets. So that's the first thing to do. The second question to ask is to say, is my blood pressure a symptom of something else? Very often, the high numbers that are recorded are a symptom of a suboptimal lifestyle. Excessive weight, smoking, a sedentary lifestyle, excessive alcohol intake, excessive stress, poor sleep patterns, such as sleep apnea, can all contribute to an elevated blood pressure. And I would always recommend that whenever patients are diagnosed with high blood pressure, they take a long, hard look at their lifestyles and modify those factors that could be contributing. This is really important because if you just take pills to make the numbers look prettier, then in some ways you've not really tackled the underlying problem, which is the bad lifestyle, and therefore the overall risk of the patient is largely dictated by the bad lifestyle rather than just the blood pressure number. So taking a tablet to make the number look prettier doesn't really dramatically alter that person's risk. It's far better to tackle all those things about the lifestyle which may make the person healthier, and in so doing the blood pressure numbers will also improve. Finally, the most important question is that you have to ask yourself is, are my numbers causing me harm? Are they doing me harm? Is my number doing me harm? Okay. Now, everyone worries about being at increased risk of strokes and heart attacks and kidney damage, but the truth is that these risks are only realized in the long term, meaning that if you've had several years of chronically elevated high blood pressure, then there's a risk of having such events. However, to expose you to this risk, there must be a degree of low-level damage going on in the body, right? It can't be that you have nothing going on in the body and 10 years later you have a stroke. That wouldn't make sense. So something must be going on in the body which may not be visible to the outsider, and the patient doesn't realize it, and then 10 years down the line they have something which is a big event like a heart attack or a stroke or something like that. So to expose you to the risks, the kind of those big risks, you have to be having a degree of low-level damage happening in the body chronically. The problem with high blood pressure is that if the blood pressure is high, then our tiny blood vessels, the tiniest blood vessels, which happen to be the ones that infiltrate our organs and supply our organs with oxygen-rich blood, they tend to also be the thinnest and most fragile. And if you have a blood pressure which is high for you, then that number does increase the risk of these tiny blood vessels getting damaged. They often can burst, and then they heal by clotting off, and therefore those areas supplied by those tiny blood vessels don't get the blood. And so because you have millions of tiny blood vessels, one or two doesn't make a huge difference, but over a period of time, as you continue to damage more and more and more blood vessels, you continue to get increased levels of low-level damage, which a person may not be able to see or sense from the outside, but are going on in the body, and eventually they culminate 10 years down the line with a bigger event like a heart attack or a stroke or kidney damage. We can look for such low-level damage, okay? In particular, we can visualize these tiny blood vessels in our eyes, in the retina. So a simple look, if your doctor looks at the back of your eyes, he'll be able to see whether there is any effect of damage to these tiny blood vessels. You can see tiny little hemorrhages in the eyes. Similarly, the tiny blood vessels also supply our kidneys, and if the blood vessels in our kidneys are affected, then even before our kidney tests become abnormal, you can detect that the kidneys start leaking more protein, because and this extra protein can be measured in the urine. So that's another way of detecting low-level damage before any high-level damage occurs. Finally, if the blood pressure is truly high for that patient, then the heart would have to work harder to pump blood around. The heart is a muscle, and therefore if the heart is working harder, if the muscle is working harder, then the muscle will hypertrophy or become more muscular. And you can see that easily by doing an ultrasound or an echocardiogram of the heart, and that will easily show whether the heart is looking more muscular. And if the heart is more muscular, then that does suggest it's working against a higher pressure for that individual. when we look at the majority, virtually all the research points to the fact that it is those people who have high blood pressure, who have high values, or those people who have low level damage, evidence of low level damage, who tend to come to harm from high blood pressure, rather than those people who don't have evidence of low level damage. Okay, and therefore, when you can detect low level damage, it becomes really important to be aggressive with lowering the blood pressure, because the number itself is probably doing harm as well. So of course I would always recommend lifestyle modification, but then also aggressively trying to lower the blood pressure with medication. And I would say that is irrespective of what the number is. So if the number is, say, 130/80 and the person's got all this evidence of all this damage, I would still be more aggressive about lowering the blood pressure. Whereas if I had a patient who had a blood pressure of 150/90 and didn't have any evidence of low level damage, then I wouldn't be so aggressive. I would still recommend lifestyle modification wherever possible, but I wouldn't necessarily jump in and give this patient medications. So, blood pressure is far more complex, and I hope that this video has been helpful in helping those people who worry about their blood pressure. You want to answer these three questions. What is your true number? Is your number a sign of a bad lifestyle? And finally, is your number doing you harm? And this will then allow you to decide what works for you. It'll give you an idea of what your number is. It'll allow you to work out whether there are any lifestyle factors that may be contributing, and of course modifying them. And when you do modify the lifestyle factors, it's good to again use a 24-hour average to monitor your progress, right? And then finally, whether you really need the medications or not. Great. So I'm sorry I haven't put well, firstly, I would say I would love to hear your thoughts about this video, whether you found it useful or not. I'm sorry I haven't done a video for a few weeks now. I was kind of burnt out, but I'm now a lot more rejuvenated, and I'm looking forward to doing more videos very soon. By the way, I'm going to the USA next week. First I'm going to Boston, and then from there I'm going to go to San Francisco and do a road trip down to San Diego via LA. So if anyone is in any of those places and you want to meet for a coffee, then do give me a shout, leave me a comment, and I'll be sure to respond. Thank you so much. By the way, I have a Facebook page, which is @YourCardiologist, and I have a website, which is www.drsanjayguptacardiologist.com. Thank you so much. All the best. Take care. Bye. Hi guys, my name is Sanjay Gupta. I'm a consultant cardiologist in York. Today I wanted to do another video on blood pressure and why the numbers are not as important as we think. Okay, so the first thing to say is thank you so much for your patience. I'm sorry I haven't put any videos out. We had the heart health seminar in August, which went really well, but then I got caught up. So I've now relaxed, and I'm gonna get some more videos out soon. So I thank you for your patience. Right, now the first thing to say is there is nothing that generates more anxiety than high blood pressure numbers. Okay, as part of my work, when I do a clinic, patients come, they have their blood pressure measured by the nurses, and the first thing that everyone worries about is, oh my God, what was my blood pressure? What was my blood pressure? And what I wanted to try and do is try and make things slightly clearer, because I don't think the numbers are that important. So let me try and explain this in a simplistic sense so that you can understand it. Okay, the reason blood pressure is considered important is because if people have a persistently elevated blood pressure, then there is evidence that they are at a higher risk of heart attacks and strokes over many years. Okay, and if you can lower the blood pressure, then there is evidence that it reduces that risk by about 25% as a ballpark figure. However, it is not as straightforward as just lowering the number, and I'm going to try and explain this by using an analogy. Okay, so imagine you're visiting a construction site, okay, and you see a sign on the construction site, which we often do, which says
people here must wear a helmet. People who are visiting must wear a helmet. So you have to say, why do these people need to wear a helmet? And the answer is that the chances of something falling on someone's head are high, and if they were wearing a helmet, that could reduce their risk of dying from injury by 25%, an arbitrary figure. But this is true for wherever we are. So, for example, I don't have to be on a construction site. I could be sitting in my study here talking to you, and if the roof on my head decides to collapse and I were wearing a helmet at that time, then the helmet would still reduce my risk of dying by 25%. But the chances of the roof falling on my head are very, very low whilst I'm in my study compared to if I were on a construction site. So in some ways, there is more to it than just the idea that a helmet protects you. There has to be something more to it. So in blood pressure, we realize that it's far more important as to who you are and what your other risks are, which decide your risk of stroke. So let me give you an example. There was a very interesting study, or an interesting paper by Erica Wallace in Heart Journal 2002, which was called Cardiovascular and Coronary Risk Estimation in Hypertension Management. And what they found, what they demonstrate is this. They said that actually, let me just bring this up. Yeah, they took two patients, they demonstrated two patient groups. Okay, both patients had a blood pressure of 150/96. But patient A was young, she was female, she had low cholesterol, she was a non-smoker, she didn't have diabetes. And in her, the risk of having a problem in 10 years was incredibly low. In fact, you would have had to treat 321 people with blood pressure medications to make any difference to one person. However, there was another patient with the same blood pressure of 150/96. He was male, he was much older, 65, his cholesterol was high, he was a smoker, he was diabetic. In him, the risk of something bad happening to him over 10 years was much higher, and therefore you only needed to treat 16 people to make a difference to one life. So what this goes to show is it's not the blood pressure that is important, it's all the other things. It's the age, it's whether you have diabetes, it's whether you smoke, it's whether you're sedentary. If you are someone who is generally fit and well, who doesn't smoke, who doesn't have any risk factors, who lives a healthy lifestyle, who minimizes his stress, who sleeps well, your risks from having a high blood pressure are incredibly low. If, on the other hand, you do all those things which are actually bad for our health, including being overweight, smoking, being stressed, not sleeping, being diabetic, etc., then the risk is much higher. And therefore, what I'm trying to get across is that the number is not important. What we shouldn't be doing is focusing on, oh my God, this is my number, I need to get that down. What we should be concentrating on is the general state of our health and thinking, okay, well, if I'm sedentary, then I need to get more exercise. If I'm stressed, I need to minimize my stress. If I smoke, I need to cut that down. Trying to move from being an unhealthy person to a healthy person makes a far bigger difference to our overall risk compared to just reducing the number or making the number look nicer. So I hope this takes away some of the anxiety that people may have when they say, oh my God, what's my blood pressure, etc. Why is the blood pressure not going down? Don't worry about the blood pressure number. Concentrate on becoming a healthier person. Concentrate on sorting out your other risks and your comorbidities, and your risk from the blood pressure will automatically come down. The blood pressure is just a number. There's nothing magical about it. It's a number. This again raises another point, which is, they every so often the guidelines change and they'll say, oh, a blood pressure of 150/90 is high blood pressure. Then they bring the value down. They change the goalpost after a few years. Now they're saying blood pressure of 135/80 is high blood pressure. So the point I'm trying to make is why is that? And the answer is because people are generally getting unhealthier. That's why. So even at lower blood pressures, unhealthy people have bad things. Bad things happen to them. And healthy people, even with higher blood pressures, remain fine. And that is why the guidelines keep changing the number, because the number is not as important. The fact that we are getting more stressed, we're leading worse lifestyles than, say, 10 years ago, means that there are more events happening. And that is why they're bringing the number down and saying, oh, treat these people early. But the way to treat them is to reduce overall risk. So thank you so much. Now, lots of exciting things. I have a new website called drsanjayguptacardiologist.com, and I would invite you to come and visit the website. I'm trying to put on lots of stuff on there, so that'll be good. I'm also on Instagram as York Cardiology, where I put these 1-minute videos in case you don't like listening to me for too long. And then we're also there's also a WhatsApp group now for cardiology patients, which I participate in, and my Facebook page is @YorkCardiologist. @YorkCardiologist. Great, thank you so much.
Good afternoon. There's a medical revolution happening all around us, and it's one that's going to help us conquer some of society's most dreaded conditions, including cancer. And the revolution is called angiogenesis, and it's based on the process that our bodies use to grow blood vessels. So why should we care about blood vessels? Well, the human body is literally packed with them, 60,000 miles worth in a typical adult. End to end, that would form a line that would circle the earth twice. The smallest blood vessels are called capillaries. We've got 19 billion of them in our bodies. And these are the vessels of life. And as I'll show you, they can also be the vessels of death. Now, the remarkable thing about blood vessels is that they have this ability to adapt to whatever environment they're growing in. For example, in the liver, they form channels to detoxify the blood. In the lung, they line air sacs for gas exchange. In muscle, they corkscrew so that muscles can contract without cutting off circulation. And in nerves, they course along like power lines, keeping those nerves alive. And we get most of these blood vessels when we're actually still in the womb. And what that means is that as adults, blood vessels don't normally grow, except in a few special circumstances. In women, blood vessels grow every month to build the lining of the uterus. During pregnancy, they form the placenta, which connects mom and baby. And after injury, blood vessels actually have to grow under the scab in order to heal a wound. And this is actually what it looks like, hundreds of blood vessels all growing towards the center of the wound. So the body has the ability to regulate the amount of blood vessels that are present at any given time. And it does this through an elaborate and elegant system of checks and balances, stimulators and inhibitors of angiogenesis, such that when we need a brief burst of blood vessels, the body can do this by releasing stimulators, proteins called angiogenic factors, that act as natural fertilizer and stimulate new blood vessels to sprout. And when those excess vessels are no longer needed, the body prunes them back to baseline using naturally occurring inhibitors of angiogenesis. Now, there are other situations where we start beneath the baseline and we need to grow more blood vessels just to get back to normal levels, for example, after an injury. And the body can do that too, but only to that normal level, that set point. But what we now know is that for a number of diseases, there are defects in the system where the body can't prune back extra blood vessels or can't grow enough new ones in the right place at the right time. And in these situations, angiogenesis is out of balance. And when angiogenesis is out of balance, a myriad of diseases result. For example, insufficient angiogenesis, not enough blood vessels, leads to wounds that don't heal, heart attacks, legs without circulation, death from stroke, nerve damage. And on the other hand, excessive angiogenesis, too many blood vessels, drives disease. And we see this in cancer, blindness, arthritis, obesity, Alzheimer's disease. In total, there are more than 70 major diseases affecting more than 1 billion people worldwide that all look on the surface to be different from one another, but all actually share abnormal angiogenesis as their common denominator. And this realization is allowing us to reconceptualize the way that we actually approach these diseases by controlling angiogenesis. Now, I'm going to focus on cancer because angiogenesis is a hallmark of cancer, every type of cancer. So here we go. This is a tumor, dark, gray, ominous mass growing inside a brain. And under the microscope, you can see hundreds of these brown staining blood vessels, capillaries that are feeding cancer cells, bringing oxygen and nutrients. But cancers don't start out like this. And in fact, cancers don't start out with a blood supply. They start out as small, microscopic nests of cells that can only grow to 1/2 a cubic millimeter in size. That's the tip of a ballpoint pen. Then they can't get any larger because they don't have a blood supply, so they don't have enough oxygen or nutrients. And in fact, we're probably forming these microscopic cancers all the time in our body. Autopsy studies from people who died in car accidents have shown that about 40% of women between the ages of 40 and 50 actually have microscopic cancers in their breasts. About 50% of men in their 50s and 60s have microscopic prostate cancers. And virtually 100% of us, by the time we reach our 70s, will have microscopic cancers growing in our thyroid. Yet without a blood supply, most of these cancers will never become dangerous. Dr. Judah Folkman, who was my mentor and who is the pioneer of the angiogenesis field, once called this cancer without disease. So the body's ability to balance angiogenesis, when it's working properly, prevents blood vessels from feeding cancers. And this turns out to be one of our most important defense mechanisms against cancer. In fact, if you actually block angiogenesis and prevent blood vessels from ever reaching cancer cells, tumors simply can't grow up. But once angiogenesis occurs, cancers can grow exponentially. And this is actually how a cancer goes from being harmless to deadly. Cancer cells mutate, and they gain the ability to release lots of those angiogenic factors, natural fertilizer, that tip the balance in favor of blood vessels invading the cancer. And once those vessels invade the cancer, it can expand, it can invade local tissues, and the same vessels that are feeding tumors allow cancer cells to exit into the circulation as metastases. And unfortunately, this late stage of cancer is the one at which it's most likely to be diagnosed, when angiogenesis is already turned on and cancer cells are growing like wild. So, if angiogenesis is a tipping point between a harmless cancer and a harmful one, then one major part of the angiogenesis revolution is a new approach to treating cancer by cutting off the blood supply. We call this anti-angiogenic therapy, and it's completely different from chemotherapy because it selectively aims at the blood vessels that are feeding the cancers. And we can do this because tumor blood vessels are unlike normal healthy vessels we see in other places of the body. They're abnormal, they're very poorly constructed, and because of that, they're highly vulnerable to treatments that target them. And in fact, when we give cancer patients anti-angiogenic therapy, here, an experimental drug for a glioma, which is a type of a brain tumor, you can see that there are dramatic changes that occur when the tumor is being starved. Here's a woman with a breast cancer being treated with the anti-angiogenic drug called Avastin, which is FDA approved, and you can see that the halo of blood flow disappears after treatment. Now, I've just shown you two very different types of cancer that both responded to anti-angiogenic therapy. So a few years ago, I asked myself, can we take this one step further and treat other cancers, even in other species? So here is a 9-year-old boxer named Milo who had a very aggressive tumor called a malignant neurofibroma growing on his shoulder and invaded to his lungs. His veterinarian only gave him 3 months to live. So we created a cocktail of anti-angiogenic drugs that could be mixed into his dog food, as well as an anti-angiogenic cream that could be applied on the surface of the tumor. And within a few weeks of treatment, we were able to slow down that cancer's growth such that we were ultimately able to extend Milo's survival to 6 times what the veterinarian had initially predicted, all with a very good quality of life. And we've subsequently treated more than 600 dogs. We have about a 60% response rate and improved survival for these pets that were about to be euthanized. So let me show you a couple of even more interesting examples. This is a 20-year-old dolphin living in Florida, and she had these lesions in her mouth that over the course of 3 years developed into invasive squamous cell cancers. So we created an anti-angiogenic paste. We had it painted on top of the cancer, 3 times a week. And over the course of 7 months, the cancers completely disappeared and the biopsies came back as normal. Here's a cancer growing on the lip of a quarter horse named Guinness. It's a very, very deadly type of cancer called an angiosarcoma, had already spread to his lymph nodes. So we used the anti-angiogenic skin cream for the lip and the oral cocktail so we could treat from the inside as well as the outside. And over the course of 6 months, he experienced a complete remission. And here he is 6 years later, Guinness, with his very happy owner. Now obviously, anti-angiogenic therapy could be used for a wide range of cancers. And in fact, the first pioneering treatments for people as well as dogs are already becoming available. There's 12 different drugs, 11 different cancer types, but the real question is, how well do these work in practice? So here is actually the patient survival data from 8 different types of cancer, and the bars represent survival time taken from the era in which there was only chemotherapy or surgery or radiation available. But starting in 2004, when anti-angiogenic therapies first became available, you can see that there has been a 70 to 100% improvement in survival for people with kidney cancer, multiple myeloma, colorectal cancer, and gastrointestinal stromal tumors. That's impressive. But for other tumors and cancer types, the improvements have only been modest. So I started asking myself, why haven't we been able to do better? And the answer to me is obvious. We're treating cancer too late in the game, when it's already established and oftentimes it's already spread or metastasized. And as a doctor, I know that once a disease progresses to an advanced stage, achieving a cure can be difficult, if not impossible. So I went back to the biology of angiogenesis and started thinking, could the answer to cancer be preventing angiogenesis? Beating cancer at its own game, so that cancers could never become dangerous. This could help healthy people, as well as people who have already beaten cancer once or twice and want to find a way to keep it from coming back. So to look for a way to prevent angiogenesis in cancer, I went back to look at cancer's causes. And what really intrigued me was when I saw that diet accounts for 30 to 35% of environmentally caused cancers. Now, the obvious thing is to think about what we could remove from our diet, what to strip out, take away. But I actually took a completely opposite approach and began asking, what could we be adding to our diet that's naturally anti-angiogenic, that could boost the body's defense system and beat back those blood vessels that are feeding cancers? In other words, can we eat to starve cancer? Well, the answer is yes, and I'm going to show you how. And our search for this has taken us to the market, the farm, and to the spice cabinet, because what we've discovered is that Mother Nature has laced a large number of foods and beverages and herbs with naturally occurring inhibitors of angiogenesis. So here's a test system we developed. At the center is a ring from which hundreds of blood vessels are growing out in a starburst fashion. And we can use this system to test dietary factors at concentrations that are attainable by eating. So let me show you what happens when we put in an extract from red grapes. The active ingredient is resveratrol. It's also found in red wine. This inhibits abnormal angiogenesis by 60%. Here's what happens when we add an extract from strawberries. It potently inhibits angiogenesis. An extract from soybeans. And here is a growing list of our anti-angiogenic foods and beverages that we're interested in studying. And for each food type, we believe that there's different potencies within different strains and varietals. And we want to measure this because, well, while you're eating a strawberry or drinking tea, why not select the one that's most potent for preventing cancer? So here are 4 different teas that we've tested. They're all common ones. Chinese jasmine, Japanese sencha, Earl Grey, and a special blend that we prepared. And you can see clearly that the teas vary in their potency from less potent to more potent. But what's very cool is when we actually combine the 2 less potent teas together, the combination, the blend, is more potent than either one alone. This means there's food synergy. Here's some more data from our testing. Now, in the lab, we can simulate tumor angiogenesis, represented here in a black bar. And using this system, we can test the potency of cancer drugs. So the shorter the bar, less angiogenesis, that's good. And here are some common drugs that have been associated with reducing the risk of cancer in people. Statins, non-steroidal anti-inflammatory drugs, and a few others. They inhibit angiogenesis too. And here are the dietary factors going head-to-head against these drugs. You can see they clearly hold their own, and in some cases they're more potent than the actual drugs. Soy, parsley, garlic, grapes, berries. I could go home and cook a tasty meal using these ingredients. So imagine if we could create the world's first rating system in which we could score foods according to their anti-angiogenic, cancer preventative properties. And that's what we're doing right now. Now, I've shown you a bunch of lab data, and so the real question is, what is the evidence in people that eating certain foods can reduce angiogenesis in cancer? Well, the best example I know is this study of 79,000 men followed over 20 years, in which it was found that men who consumed cooked tomatoes 2 to 3 times a week had up to a 50% reduction in their risk of developing prostate cancer. Now, we know that tomatoes are a good source of lycopene, and lycopene is anti-angiogenic. But what's even more interesting from this study is that in those men who did develop prostate cancer, those who ate more servings of tomato sauce actually had fewer blood vessels feeding their cancer. So this human study is a prime example of how anti-angiogenic substances present in food and consumed in practical levels can impact on cancer. And we're now studying the role of a healthy diet with Dean Ornish at UCSF and Tufts University on the role of this healthy diet on markers of angiogenesis that we can find in the bloodstream. Now, obviously, what I've shared with you has some far-ranging implications even beyond cancer research, because if we're right, it could impact on consumer education, food services, public health, and even the insurance industry. And in fact, some insurance companies are already beginning to think along these lines. Check out this ad from Blue Cross Blue Shield of Minnesota. And for many people around the world, dietary cancer prevention may be the only practical solution, because not everybody can afford expensive end-stage cancer treatments, but everybody could benefit from a healthy diet based on local, sustainable, anti-angiogenic crops. Now, finally, I've talked to you about food, and I've talked to you about cancer, so there's just one more disease that I have to tell you about, and that's obesity. Because it turns out that adipose tissue, fat, is highly angiogenesis dependent. And like a tumor, fat grows when blood vessels grow. So the question is, can we shrink fat by cutting off its blood supply? So the top curve shows the body weight of a genetically obese mouse that eats nonstop until it turns fat like this furry tennis ball. And the bottom curve is the weight of a normal mouse. If you take the obese mouse and give it an angiogenesis inhibitor, it loses weight. Stop the treatment, gains the weight back. Restart the treatment, loses the weight again. Stop the treatment, gains the weight back. And in fact, you can cycle the weight up and down simply by inhibiting angiogenesis. So this approach that we're taking for cancer prevention may also have an application for obesity. The really, truly interesting thing about this is that we can't take these obese mice and make them lose more weight than what the normal mouse's weight is supposed to be. In other words, we can't create supermodel mice. And this speaks to the role of angiogenesis in regulating healthy set points. Albert Szent-Györgyi once said that discovery consists of seeing what everybody has seen and thinking what nobody has thought. I hope I've convinced you that for diseases like cancer, obesity, and other conditions, that there may be a great power in attacking their common denominator, angiogenesis. And that's what I think the world needs now. Thank you.
So these drugs aren't exactly, they're not exactly in mainstream cancer treatments right now. For anyone out here who has cancer, what would you recommend? Do you recommend pursuing these treatments now for most cancer patients?
So there are anti-angiogenic treatments that are FDA approved. And if you're a cancer patient or working with or advocating one, you should ask about them. And there are many clinical trials The Angiogenesis Foundation is following almost 300 companies, and there's about 100 more drugs that are in the pipeline. So consider the approved ones, look for clinical trials, but then between what the doctor can do for you, we need to start asking, what can we do for ourselves? And this is one of the themes that I'm talking about, is we can empower ourselves to do the things that doctors can't do for us, which is to use knowledge and take action. And if Mother Nature has given us some clues, we think that there might be a new future in the value of how we eat. And what we eat is really our chemotherapy 3 times a day.
Right. And along those lines, for people who might have risk factors for cancer, would you recommend pursuing any treatment sort of prophylactically, or simply pursuing the right diet with lots of tomato sauce?
Well, there's abundant epidemiological evidence, and I think in the information age, it doesn't take long to go to a credible source like PubMed, the National Library of Medicine, to look for epidemiological studies for cancer risk reduction based on diet and based on common medications. And that's certainly something that anybody can look into.
Okay, well, thank you so much.